Joining us this morning for us. This is Rhea is a medical student at the University of Toronto, and she'll present herself in a minute. But for her right now, it's about 12:30 a.m. in the morning in Toronto. So thanks for thanks for joining us so late in the evening. I'll let you go. I mean, today's Rhea's presentation this morning is going to be on reinforcement learning. Remember yesterday we talked about the 3 different types of machine learning. We especially talked about unsupervised learning yesterday, but there's supervised learning, unsupervised learning, and reinforcement learning. And so today Rhea is going to give you a little talk about reinforcement learning and one possible application in diabetes, which is an area of interest of Rhea's, or one of many areas of interest. Now she's interested in thyroid because she's working with me on thyroid. But this is something that she has agreed to present to you. So thank you. So Rhea, take it away. It's all you. Thank you.
Everyone can see my screen, right?
Yes, absolutely. No problem.
Okay, awesome. So nice to meet all of you. My name is Rhea. Thank you for the kind introduction, Dr. Shira. So yeah, I am a medical student at the University of Toronto. I am HCC3, so in my third year now. And I'll be talking a bit about reinforcement learning, specifically for the treatment and optimization of hypertension and type 2
Can we make it bigger?
diabetes. So really seeing how we can optimize the care of patients by applying different tools. And it's pretty neat. That feels pretty neat. that's a quick explanation of reinforcement learning. If anyone has any questions, please just let me know. Thank you.
Thanks, Rhea. Oh, we got you back. Perfect. So that was a great presentation. I suspect it might have been a little quick on the clinical side. So maybe I'll ask you a few questions if you don't mind, just because that's what you do as a medical student. But just a show of hands here, who's in the medical field, in healthcare? Yeah. So you can't see Rhea.
Saying that one time, no, for a second.
Can you see? You can't see? No. I was just saying. I was just saying to these. Is this working? I was just saying to the audience. Oh, there we go. Now we're getting feedback. Okay. I was just saying to the audience that there's not very many healthcare providers here. So this is more of an engineering crowd. And so that's why I'd like you, if you don't mind, to step us through a little bit of type 2 diabetes. I don't think, who knows what HbA1c is? Oh, so there's a few. There's a few. That's awesome. But that's the same people who put up their hands that they're in the healthcare field. So nobody else really knows what glycated hemoglobin is. So if you could just, if you don't mind, if you could just step us through, high level type 2 diabetes, what the risks are, why, high blood pressure is a concern, why, you're on metformin, just, a nice little overview for them to understand, what the application of reinforcement learning in this case was for.
Yeah, for
Thank you.
sure. So I think for the perspective that really good what we had to have. Yeah, I'll just quickly give a brief explanation on type 2 diabetes. So type 2 diabetes is pretty prevalent across the world, but on broad strokes, it's a chronic metabolic disease, which means that the body's going to create various hormones, and the pancreas can, but the body can't use the sufficient hormones to regulate blood sugar, which is glucose. While glucose is important, it gives us energy at the end of the day to do what we want, but if your body's
Yeah, that was absolutely perfect. Thank you, Rhea. And the reason I wanted that's great is educational for those of us in the room that were not aware of type 2 diabetes and what it represented. So thank you. That was perfect. But I think also what the reason I asked you, and you described it perfectly, because I knew, being a medical student, is that you emphasize the complexity of type 2 diabetes. And I think that's what brings us back to the engineering today, which is we're discussing reinforcement learning. And when you aptly described states in action, you need to understand how the states are derived, because Rhea kept it very simple in her presentation. That how many states did you have? 4? Or yeah, you had 4 states, right? So if we were to actually model type 2 diabetes, how many states do you think we would actually have? Do you think it would only be 4? Oh, if not more, right? Because each combination of all of your test results, all of your family history, all of your presenting symptoms creates states. And your model needs to make sense of all of those states and appropriate actions in order to give you an answer. And so even though Rhea is, very, very appropriately said how amazing reinforcement learning is, I'm going to say how difficult and almost impossible it is to model using reinforcement learning in medicine. I don't want to be the, Debbie Downer, but I'm going to be, because it is almost impossible to achieve success in reinforcement learning in medicine. Not because modeling is not possible, it absolutely is. The problem is we don't have the data in order to model it appropriately. And so maybe that's something we can discuss now. So by the way, Rhea, we're going to dig into the engineering here. You're welcome to hang on, but if you're just like dying to go to bed, you're more than welcome to drop off. But of course you're welcome to stay on. But when we're modeling reinforcement learning, so I'm going to put you in a position that I've just hired you to produce for me an algorithm using reinforcement learning for type 2 diabetes. You've just learned how to do it. You all understand, to a certain extent, the disease. So how do we proceed? What's the data we need in order to train our first model? What do we need? So the data we need is exactly what Rhea described, which are various states, actions, and rewards and penalties, right? So just think, where do you get that data? Do you just ask Rhea? Do you say, hey, Rhea, can you give us the data? Where do you get that data? Where does it exist? Where does that data live? God knows, right? Most probably in the patient charts. It's probably going to be on paper in India, because not everything is digital in India, correct? All your patient charts are not in digital format. Some are, I'm sure, but not completely. So how are you going to get that data? You're going to have to first transcribe all that data. You can do it electronically into some format. And then you're going to have to parse that data to derive all of the states, all of the actions, all the rewards, and all the penalties, correct? So now you tell me, let's say we're successful at doing that, which is a big if. What's the big problem here that we discussed yesterday, and we will continue to discuss the entire week? What is the biggest problem we have with that data set? Gold star to anybody who comes up with it. Not an easy one. What's the problem with that data? We've collected successfully all the data from type 2 diabetes patient charts, all states, all actions, all rewards. We have the data. I'm telling you, we have the data. What's the problem with that data? Yes, absolutely biased. And what's the bias? Oh, that's good. Excellent. You're right. Absolutely. So we don't have the patient, we don't have the non-patients, right? So patients that would not be presenting and give us the data, but who are important as well because they would have the same or similar trajectories, correct? So the untreated patients. So you're absolutely right. So excellent. That's one bias. What's another one? Sure. So that'd be class. So class imbalance. So that I think it's on the same line, right? So some are missed. Absolutely. But how about the ones that we didn't miss? We still have a major problem with that data. Major problem. So you see, I'm just pointing out to you right now, this is the biggest problem being an engineer who does not have access or does not know domain knowledge. Because you would go ahead, because I just told you we got the data. So then you're really happy, aren't you? Like, let's go, right? But the problem is the data is not correct. And the biggest problem in medicine is called confounding by indication. So meaning that there's a confounding effect, statistical term related to bias, and what you're doing is you're only observing because the patient has the disease, or you're only observing because the treatment was given because the indication was there for the patient. So the problem for us in reinforcement learning is we need all possibilities to be present for us to train the model. But what do we only have? We only have how the patients were treated. We do not have at all what the outcomes would be had they been treated differently. Do we? We don't have that. So how does the model learn that? It doesn't. And so it's an extremely biased model. And that is a problem we cannot avoid. Well, unless we live in another dimension or something, it's not possible. So retrospective data, historical data, is not going to help us. And unfortunately, in reinforcement learning, even in the future, if we did prospective data, we still won't get it-ish. It could be better. Because what are we going to do? We're going to ask, some patients, do you mind if we treat you this way instead so that we can learn? Well, no. I mean, we can't experiment on humans, correct? So that is the biggest, well, there are many problems, but that's the biggest problem with reinforcement learning, is we do not have the full data set, and we never will. So does it mean that we give up and we don't do it? No, of course. That's what we do for a living, so let's have fun and work on it. But you have to realize that is what you as an engineer has to work with the domain knowledge experts, so let's say Rhea. That's who you have to work with in order to best model your data, even though there are limitations. And so there's the other step that, what Rhea, pointed out was interpretability. Interpretability is extremely difficult from reinforcement learning models because of that problem of bias, the problem of training. It's very difficult to interpret if that, what it provides is appropriate, right? Because it's just giving you a decision. Is that right? The physician's going to say, how do you know that's right? And you're going to say, well, that's the best the model could do, and they're going to be like, I'm not going to do that, right? So that's the challenge of reinforcement learning. And it's a great example. Type 2 diabetes is a great example because it is a huge problem across the world, everywhere in the world. And the change that is required to treat it is actually really simple. I'm not going to preach or anything, okay? But I'm just going to tell you, drug treatment is big because pharma companies make a lot of money. But I can tell you right now, the vast majority of people with type 2 diabetes do not require medication. They require lifestyle changes. Period. Some people require medication, but it's because either they did not change their lifestyle and then they got to my age, or genetics is just really poor and they need medication. But the vast majority don't. And so there's a problem too, if you're training. How do you incorporate people who have done or incorporated some lifestyle changes into your modeling? Because that's a huge problem. Because who here, and I've got to say, like when I look around at people in Mangalore, you certainly don't have the obesity problem that we suffer in North America. I mean, it's everywhere, but you definitely, people look a little leaner here for sure. But how many people in this room have been told or asked or recommended to either lose some weight or be more active or stop smoking? Has anybody has anyone said, hey, come on, man, you gotta stop eating a little bit, don't smoke, right? Okay, well, I won't single you out, but I can see from people smiling that, some people have been asked. So the thing is when you're first told, you're going to say, yeah, oh my God, I'm on it. Whew. But how long does it last? A month? 2 months? And then you go right back to where you were. Not right, you just slowly, you make an effort for about 2-3 months and then you slowly kind of go back to eating more and smoking, right? And so that's a huge problem for state transition. Because when you have state transition data, depending on when you capture it, like how often do you see your physician? Once a year at most, right? At most, right? But some people see them more often than others. So that's a snapshot in time. So when you saw the physician and then when you saw them again, you may have actually, been good and lost some weight and stopped smoking. But the year later, by the time you went to see the physician again, it was too late. You already put the weight back on and you started smoking again, right? So when you had your blood test, so it's not, you know what I mean? Like the state transit, that's a problem for data, right? That you're not capturing truly all the state transitions. You're capturing snapshots over time. So that's another problem for state transition, right? Is you don't have the full picture, right? So, being refractory to treatment, there's a whole bunch of reasons that you're refractory to treatment. And so, that's probably one of the biggest successes of Ozempic. I'm sure you've heard of Ozempic and all the other medications for type 2. They're type 2 diabetes medications. But as Rhea pointed out, it's being used for weight loss in people who can afford it. Because one of the side effects of the medication is you lose weight, right? Because it stops your appetite, right? You're not as hungry anymore. But it is actually supposed to be a type 2 diabetes medication, right? That's the purpose of the medication. But because you have to take it every day, then it does do its job, right? And because you're just taking a pill and it happens. So that's the advantage of drugs, right? But lifestyle changes is really the solution, truly is the solution. And I say that because I'm a vascular researcher, right? So a lot of my PhD was in vascular, health in children. And I can tell you that it all comes down to how healthy your arteries are, right? And whatever effects they have. And type 2 diabetes is one of the reasons that you're going to suffer heart attacks and you're going to lose circulation and the extremities and stuff like that. So it's nice to bring these together, right? And this is a fantastic example of where, as an engineer, if you don't dig in, like if you don't really spend time with whoever is your partner for the domain knowledge, I can't guarantee you're going to fail, but I'm going to say the probability is very high you will. Okay, because if you don't understand the process, there's no way you're going to be able to model it correctly, right? And so there's a good example of what we're going to continue to talk about the whole week. But I don't want to dissuade you from reinforcement learning. I'm not. I'm just showing you the challenges of reinforcement learning, a little bit like what I said yesterday, that unsupervised learning is wonderful. It's a lot of fun. I enjoy it in particular, especially statistically. It's fantastic to do unsupervised learning. But unfortunately, how applicable it is and how much you can use it is limited, right? And so reinforcement learning is the same. Okay, that it's still pretty underutilized in healthcare and medicine for exactly that reason, is we just can't model all the states, right? It's a limitation, right? If it's an engineering problem, like in cars or whatever, then you can model all the states because you know all the states and you can get the data of all the states because you can test the data that way, right? But you can't do that with humans, which is the problem. Okay. Rhea, did you drop off, Rhea? I can't remember. It looks like she did. I'm just guessing. Does anybody have any questions? Oh, look at you. You're a rock star. So, does anybody have any questions for Rhea? After I just, bummed everybody out about reinforcement learning? Anybody? No? Any questions on type 2 diabetes? Any questions on the application of reinforcement learning? You guys are all sold? It's all good? Has anybody here done reinforcement learning as an engineer? Nobody? No? Yeah, I'm not super surprised. Right? It's not super common. No? Everything's good? Okay, well, Rhea, thank you very much. That was really kind of you to join. And that was a fantastic presentation.
Thank you so much. I'm just going to bed now. I apologize. Thank you again.
Thanks. All right, so where are we at? What's next? I can't remember. So while we're getting the slides ready for the next presentation, I'm just going to warn you guys that we're talking a lot yesterday, and we need a little more participation from you guys to access this. All right, so I'm giving you a heads up. I'm going to be expecting some answers from you guys. I won't give you too hard a time, but you guys usually engage a little more over there. Perfect. No, that's fine. You know what? Because when I walk away from the mic, people still hear me, so that's all good. As long as people can hear there, that's fine. Yeah. Perfect. Okay, we can. Oh, do you want me? Yeah, do I have the clicker? Yeah, sure. Thank you. All right, I can move forward. You guys know who I am, so that's not a problem. There are my disclosures. Okay, so what are we talking about now? So we're going to talk about women's health, And so it's funny, why would I be talking about women's health, right? Like that's not my expertise, right? But the reason I'm talking about it is because of the impact it has on me as a data scientist. Okay, so always think when I'm talking about anything, it's because it's somehow related to my work as a data scientist. Okay? So in this case, what I'm bringing up here, can anybody guess the reason we're talking about women's health? Obviously, women's health is very important. Men's health is very important, right? But that's not the issue. Why are we talking about women's health today in the context of data science? Why are we doing that? Why is it important for us to point out women's health? We already talked about it yesterday. Now we're going to talk about it later today too. So in India, how much attention is brought to women's health versus men's health? Do you think it's equivalent? Do you think it's the same? No, not at all, right? Because culturally, that's the way it's been. But it's changing. It has certainly changed in North America, much quicker than in India. But for a data scientist, that's a huge problem. Because there's bias. Unless you want all of your work to only serve men, then you have a problem if you have an underserved population, which are women, when it comes to data collection. And so that's a huge problem. And it doesn't, religion and culture should not come into play for our job. The only reason it should is for awareness in bias of the work we do. Okay? So I'm not saying it's right or wrong. I'm not saying, culturally it's right or wrong or religious is, I'm not saying that. I'm just saying from a data scientist perspective, you must be aware of it. And you must report, for instance, that your algorithm is how it is generalizable, right? Meaning who can use or where and when can your algorithm be used? And that's when you realize the problem of bias. So in healthcare, in the world of healthcare, there are certain traits, certain features, certain variables that are always important. And the first one is sex. Sex at birth. I always have to use that term now to differentiate it from gender. Okay, gender is assigned. Sex at birth, you're born that way. And it's a physiological fact, right? So that one's extremely important in anything you do in healthcare. Age is extremely important in anything you do in healthcare. Your BMI is extremely important in anything you do in healthcare, right? Your body mass index. Very important. Your blood pressure, very important. Because these are key indicators of health, right? So you can never forget those. And then there's a whole plethora of other ones, right? A whole bunch of other variables you need to be aware of. But those ones are key. And so talking about women's health is important just to bring to light how it's different from men. And that's the reason, I believe, that's why we were asked to talk about it today, was to do this, okay? And so we're going to talk about it today, just very quickly, and just talk about how AI can assist in that fashion, okay? So, no difference to men. Obesity, well, maternal health, that one's different from men. Breast cancer and mental health. So, breast cancer, do men get breast cancer? What do you think? Yeah, they do, but it's just uncommon. It's uncommon, right? We don't have the same risks as women do. Mental health, what do you think the balance is? Same? Equal? Yeah, pretty much, right? Pretty much. One of the biggest problems is reporting, right? Okay, so these are the objectives. I think I just went through that, which is great. So why focus on women's health? I think we just went through that as well. It is foundational to community health, right? And, historically under-researched and underfunded. So that is just across the world, like across the globe. It is a fact, right? So for instance, in North America now, it's equivalent. Okay, so the amount of research, it's all equity, right? So are we okay now? What do you guys think? We okay now for women? It is absolutely fair in North America now. All the attention, everything is. So are we good for moving forward? What do you think? Are we good? Problem solved? You guys in the back over there, young engineers to be. So what do you think? Are we good? Put your hands up if you think we're good now in North America. Okay, put your hands up if you think we're not good. Okay, you guys have to vote. You gotta put your hand up, man. Like seriously. You can't be all undecided. That's just, it doesn't work. It doesn't work. So what do you guys think? So are we good? Like, is North America good now for women? Are all our algorithms going to be fair?
Can I answer that? I don't know.
You don't know. That's a good answer. So no, we're not good. But why? Because what contributes to training all of our algorithms? Historical data. So we're not going to be good for many years because it depends on how far back you want to go. If we only go back 5 years, yeah, we're good. But if you're going to go back 20 years, 25 years, 50 years, we're not good because we don't have the equivalent data in men and women. So remember that. We're not out of the woods yet. It's still hard. Okay, high mortality, morbidity, and preventable conditions, of course. Gender disparity, so that one is gender or sex disparity in research, right, and access, okay? So these are very busy slides, by the way. So this is a student of mine, Ravinia, who put these slides together with me. And I forgot to acknowledge her, so my apologies. So she's an undergraduate student of mine that's been working with me for years. And she helped me with these, putting these slides together for you today. So I keep telling her, I say, make slides that are a little simpler to read and stuff. But it's very hard. She just loves putting in a lot of stuff. But okay, so what are key challenges in women's health, right? Of course, number one is going to be maternal, right? Health complications for sure. Menstrual, that's just something that is, for men, many men anyway, they don't even know what that is, right? But that's just something that women have to live with for quite a long time until menopause. And it is disruptive, right? Mental health, same as men. Structural barriers is where we're trying to get away from that, and that's going to be social stigma is a big one, right? And I am guessing that in India that's a problem. Okay, social stigma of women's health is going to be a problem, right? And that's going to lead to disparity. All right. So the other thing is, of course, your age. Remember I said age is a concern? Well, absolutely, in women, age is a thing, right? Because you're going to have young adults, the middle years, and the later years. Many illnesses, complications are age dependent. Okay? So breast cancer, for instance, tends to be diagnosed, in the kind of the middle years, right? Sadly, actually, I just found out yesterday, no joke, my niece was diagnosed with breast cancer, and she's 30. So, and it's in the family. It's in my brother-in-law's family. My sister-in-law's family. But it's a reality, right? It's a reality. So it's something to keep in mind that, time is a factor right, for a lot of these diseases. So for women, even more so because of, their what's called childbearing years, so the years that you can have children, right, versus postmenopause and as a child, right? Okay, and we're not moving. There we go. Okay, so this is just a quick comparison of Canada to India. I would say it's fairly similar on some aspects, but some of them we'll bring up which are interesting. So maternal mortality, it's a reality, right? It happens. You have complications during childbirth, and it can lead to mortality and morbidity. So in this case, mortality, you have 8 in 100,000 in Canada. Tends to be more in rural and indigenous areas, no surprise, right? If you're not in a major center in a hospital, the risk increases. In India, you have 103 to every 100,000. That's a pretty big difference between Canada and India, right? So that's one thing. Access to care in Canada, as we discussed yesterday, is universal. Access to care in India is not. And I did a little checking on that one, and the numbers are not official, but it would appear about 30 to 40% of your population do not have health insurance. Wow, that's huge, right? You're over 1 billion, and you've got 30 to 40% don't even have health insurance. What? That's just massive. Anyway, so just to say. Breast cancer most common, right? Of course, so in Canada. Cancer burden, you have breast and cervical cancer, and late detection is a problem. So there you go. There, once again, time is an issue, correct? So when you're an engineer and you're thinking of these things, when you're modeling, you got to think, if you're going to be comparing or you're making a model, remember, very often you're doing cross-sectional work, right? You're just looking at a snapshot in time. But just remember, what happens in Canada is different than what happens in India because of late detection. Or what happens in the area I work in, which is LMICs, right? Low middle income countries. We're a high income country. Low middle income countries have that problem of late detection. It's a huge problem. The big one here, remember, you see here cancer burden is breast and cervical. There's no cervical in Canada. Why do you think that is? Because the cervix are healthier in women in Canada? Yet we have a healthier cervix? What do you guys think? What's that? Wow, I wouldn't have expected that answer. That's a good one. So yes, vaccination for sure. Excellent. But there's another one that I would, yeah, that's a good point. But there's another one that might be screening, bingo. Screening, right? Screening. If you have like 30 to 40% of your population don't have health insurance, they're not going to pay to be screened for cervical cancer. Correct? Like it's not going to happen. So that's the reason that cervical cancer, which is, I'm not going to say easily avoided, but somewhat easily avoided, is not here in India, and that's the reason. Okay? In men, for instance, well, not in men, but both men and women, but very, very often in men, colon cancer is very easily avoided. Right? But why do you think people don't or suffer colon cancer? Because they don't want to go and see the proctologist. They don't want to get a colonoscopy because for them that's just like, no one's going down there, right? But it's a problem because colon cancer is actually treated immediately. When you go for a colonoscopy and they find a polyp, they clip it off immediately. There's no waiting, no, they just clip it off, and then they check to see if it's cancerous. So you've already been treated, you've already been detected and treated in one session. So colon cancer, really can be avoided, truly. And cervical cancer is the same way, right? There's an interesting, I don't know if you guys, anybody in biology here? Cell biology? Anyway, in cancer research, there's these cells called HeLa cells, and they come from the cervix of this patient many, many, many years ago. Helen Land, I believe. HeLa, Helen Land. And they were instrumental to the research of cancer, these cells, this cancer cell line. Anyway, just a little aside on cervix. Okay, Mental health, I'm going to say same idea in terms of mental health, but once again, in India, there's a severe stigma, probably for male and female, correct? Would you guys suspect that? So reporting mental health or suffering mental health and being okay with it, would it be about the same for men and women? Or, what do you guys think in India? Ish? It's a stigma in Canada too, but probably not as, I'm going to guess, probably not as much as in India, okay? Because I just know culturally, you just deny it, right? And so, and we do too, but probably to a lesser extent. So that's just something to take into consideration. Last one, of course, we don't have that. Men is menstrual health, and we have widespread access in Canada. In India, menstrual health will be limited access to, how to deal with it. Would be hygienic products due to cost, right? And cultural taboos. So meaning, like, do you talk about it? Do you share it? How do you deal with it in India, right? Is a problem, and it's just clearly going to be an issue. And so the reason I bring this up is because let's say you're a successful engineer. You do a wonderful job with Dr. Shikhar, and you get a job, overseas or in Europe, right? The data is different, and you need to keep that in mind when you're a data scientist, okay? The questions you're going to ask, the data curation you're going to have to perform is going to be different depending on where the data comes from, okay? So how do we overcome the gap, right? So in Canada, specific actions, there's mobile clinics, especially in remote and indigenous populations. Culturally tailored reproductive and mental health programs, so that we're moving towards that in North America, especially in Canada. More AI integration and early screening for younger women. So inevitably a lot of it is education, right? So what's culturally acceptable? When and where can you educate women on women's health is a target for us. So in India, specific actions, AI-powered screening, smartphones. Remember we talked about that, right? So the use of your smartphone is something that you should be thinking of, because the smartphone, it's impersonal, right? So especially for, let's say, mental health, right? So if you have an app, that's AI, right? It's a chatbot. If you have the stigma of not wanting anybody knowing about mental health issues, would you be more comfortable speaking to an AI chatbot or asking to speak to a mental health professional? Duh, you're going to talk to your phone. So there's an example of how powerful AI could be with just a simple app. Now, of course, you're going to say, well, that's not the same as a psychiatrist, Sure, it can't prescribe medication, but it can definitely do, what's called talk therapy, right? So think of how impactful that can be on the level of mental health requirements. So if you're schizophrenic, a phone's not going to help you. But if you have some anxiety that you have to work through, you may suffer a little bit of ADHD, obsessive compulsive, I don't know, something very minor that's you just need a little support, in order to help you manage your job. You're anxious, and you have to deal with that, you're not sleeping well. So that's something that definitely you could learn and use from a phone. And so think of how many people that represent. You'd be surprised, it's actually a lot. It's a lot of people. There aren't that many, in comparison, there are not that many people that suffer from schizophrenia, right? Schizophrenia is probably the end, the extreme of any mental illness, right? It's kind of a bucket that represents, we don't know what's going on, but it's really bad. That's what schizophrenia is. And it's very difficult to treat. Okay, so AI-powered mental reproductive health education in schools. So I love that one. This is always, we've been talking about that for years, right? Public-private partnerships for maternal care outreach. So this one's always, this one, when you hear this, you always think, oh God, right? Because the problem is it's such a simple solution, but it's almost impossible to be successful. And the reason for it is because it's just not culturally accepted, right? So if it's not culturally accepted, you can say it all you want. It's not going to happen. You're not going to be successful in implementing it in schools. So I'm not saying don't try. Of course, that's not my job. I'm a data scientist, right? So that I'll leave that up to, social. But what I can say from a data scientist perspective is, oh yeah, we got one of these again, right? And how much time do students spend on their phone? Way too much. So the ability for them to plug in for a little bit of, menstrual and reproductive health on their phone, why not? Because the thing is, you're going to say, oh, they're not going to want to know. They're going to want to know. They're going to want to know. I have 2 daughters, right? Been there, done that. So, they do want to know because they're very anxious at that age, if you haven't had children. They're very anxious at that age because they don't know what the heck's going on. They don't know what to do. They don't know who to ask, right? They need guidance. So if you give them a tool that they can use, they're going to use it. Telling you they're going to use it, right? They would rather learn from here than to ask anybody because they're uncomfortable about it, right? So just another example of how easy that would be. Think of it, how easy it would be to put an app together. So what do you think the biggest problem is if you put an app together? How long would you think it would take to put an educational app together, a static website, educational information on menstrual? How long do you think it would take to put that together? You guys in the back, come on, someone's got to give me a time. How long? One hour, 5 hours, 10 hours, 2 weeks, a month? How long? Who here has put a website together? Just put your hand up. I created a website. Just a plain static website. Okay. Come on, one person. Come on, seriously. Are you guys engineers? Am I in the wrong room? So come on. Putting a website together now with AI will take you about an hour. About an hour. You can do it quicker if you have more experience, but it'll take about an hour. Static. It's not a web app. There's no actionable anything. There's no data. There's nothing. It's just read. Hour. Okay? You can put it out and deliver it on a phone. You can turn it into a web app and put it out, and people can use it on their mobile in maybe a day. Because if you don't know how to do that, it's a little trickier. But it's going to take a day. If you want to put an app onto the web store, onto the app store, that's going to take a little longer, right? Because you have to get it authorized through the Indian, app store, and that's going to take a month. It's going to take about a month. I know because I've done it. Actually, I'm going to share with you guys one of our apps that we've done. Hopefully, we actually asked to put it on the Indian app store. It might be accessible for you guys by the end of the week. So we'll see. So that's something you can do. So why does anybody here? Do you know of an app where you can get information? Anybody? Any women? Where do you guys go for information on that? Probably right now you're going to ChatGPT, right? Why not? Everyone's going to chat, but why wouldn't you go to ChatGPT? Whoever here thinks that young women, young girls are not going to ChatGPT to ask these questions are delusional. Of course they are, right? That's who they're asking. They were Googling it before, and now they're going to ChatGPT. It's free, why wouldn't they ask? They're not embarrassed about it because they know they're talking to ChatGPT. So what's the problem with that, you data scientists? So you just hit it right on the second one. It may not be what we want. So it may be wrong, yes, absolutely, and that's a concern. There's no doubt. But that's just a reality, right? How do you know that the website's right? Right? But the key one is it may not be the information we want them to know. So my community. What do we want them to know from my community, my school? So then that's why apps are good, because it will be an app that's adopted by your school. That's a form of authority. So if you share that, you create that app and you share it through your school and you say, hey, here's an app. Come here if you want information, And if you need more information, then you give some links to the Indian government. I don't know, there might be some educational, information online. It would take you an hour. It's not going to take an hour for the school to authorize the use. That's going to take months. But you could get all this done in no time. And then you could start putting in some AI. So that's where you could create AI agents. Has anybody created an AI agent here? Okay, so what are you guys waiting for? Creating an AI agent is absolutely in your realm. You are capable, all of you, even the students in the back that are being extremely quiet. You are all capable of doing it because you just have to ask ChatGPT how to do it. I've created many AI agents. Okay? My company does it all the time. Easy, easy, easy. The tricky part is the first time you do it, and the second time, and the third time. But eventually you'll get really good at it. But the first time is a little tricky because you have no clue how to do it. But now you don't have to call me and ask me how to do it. You just have to ask ChatGPT and we'll tell you exactly how to do it. But the challenge, of course, is then just doing it. That's what's hard, right? That's the barrier, is you actually have to do it. But, well worth it. So if you use AI agents, now what you're doing is you're elevating a static website to an actionable one, where you can ask specific questions. And for instance, an AI agent, you can incorporate guardrails. So that's where you can guide your user to only access certain information. So it's an AI agent that accesses LLMs, large language models, but it's restricted. There's only certain prompting that is permitted. And by doing so, then you are in control. Your AI agent is in control of, let's say, students that are accessing information, and there's certain information you don't want them to get back, then you can put that in your AI agent. Okay? So that's, in medicine, that's very important. All right. AI policy and solutions. So this one here we've already talked about a little bit. Shared, global solutions and telehealth and, data equity and all that stuff. And we're talking about this already. But just, to reiterate, inevitably you do need to be mindful of what's appropriate and what's not. Okay? And in Canada and in India, you are going to be, governed by that, right? So, first person to ask is who you report to, right? So ask your boss, is it okay if we do this? Just make sure your institution's okay with what you're doing, or, and then you go up the chain, right? Ultimately, you're going to have to make sure there's no breach of whatever it is you're doing, right? A regulatory level. You do have, I can't remember the name of it, but in India you do have an equivalent FDA. It's a little bit different because you have you have an overarching, FDA-style regulatory body in India, but then the state plays a role for delivery of medical devices and drugs. So it's a little bit different than the FDA, but it's very similar. And so that's just something you have to be, that's the ultimate, right? That's the ultimate. If you do anything in medicine, you got to make sure that whatever you're doing is regulated. If you do an app that's just educational, it's not regulated. It's okay. You don't have to worry about it, right? Even if you're providing information about health, that's a wellness app. It's called Wellness. It means it's an app for health, right? If you give diagnosis or you give treatment advice, you've crossed the line. So don't do it. You can't do that, okay? But you certainly can educate, right? You can give advice about description of illness. So why are we doing it? Well, because we want to reduce morbidity and mortality. And unfortunately, what happens in women is it's kind of an accepted thing. Well, women give birth to children, so they have to assume the risk of death when they give birth to the child, right? But that's not really fair, is it? The human race won't exist if we don't give birth to other children, right? So it's a problem. We have to do it. So the question is, how can we do it and minimize the death of the mother, right? So there's just an example that where we can bring in data science in order to help that. And that's going to be by looking at what are, the causes of death. So what are the risks and what are the causes? And that can be modeled. That can be modeled, right? Sometimes it's obvious, right? If mothers are giving birth outside of a, I'm not going to say clinic. It doesn't have to be a clinic. You can give birth anywhere. But if you're outside of anywhere where there's resources, right, in order to support that birth, then you're at risk, right? So then it's obvious. You don't need an algorithm to help you with that, right? But when it gets a little bit more complicated, so meaning that you are giving birth in a secure area, a safe area, then you're going to be wanting to ask the questions, history of the mother, right? Historically, what are our health concerns and stuff like that? How about the terms of the baby, right? So the infant, or the fetus in this case, like how did pregnancy progress? All that kind of stuff, right? So all of that can be modeled. And so there's another example of how you can get into modeling risk, right? So you could model risk. You could model outcome, right? You could model requirement. So that would probably be, in my opinion, be the easiest one to do, okay? So you've already created an app that gives education for young women. Now what you do is you add in a little bit of an agent that says, oh, congratulations, you're pregnant. So now what do? Now you would assess risk. And that could be done through an agent, just asking questions. Just historically, how are you going to prepare for pregnancy? How are you going to prepare for childbirth? Where are you going to do it? Do you have support from your family? Do you have health insurance? Do you have complications? Like right now? Like, are you healthy? Are you a healthy person now? All these questions can be asked, and then at the end it can say, yeah, wow, that sounds great. You're going to do great, Or it might say, whoa, careful, for what you've just presented, you would represent a high-risk pregnancy, right? And then to do something about it, right? And so that's easy. That's an app. It's just continuing your app, right? Easy to do. Now, once again, it has to be community-driven. It has to be. Because if not, think of it, it would already be done. Because it's so easy, it already would have been done. The reason it's not done is because no one adopts it. No one will use your app. They will only use it if it comes from your community. That's the only way it's going to work, right? In my opinion, in my experience. Okay, so now we're getting into more examples of breast and cervical cancer, okay? So breast cancer is by far the most common. 1 in 8 for us in Canada. I would suspect it's probably similar in India. And in terms of, that's, you don't contract it, but you develop breast cancer. But death from it is going to be very different in our two countries, right? So inevitably. And so that's, and then cervical cancer is a problem in women, and we've just gone over that. And so there's kind of that's not an easy one though. So I was going to say, oh, that's an easy one, right? No, it's not an easy one, because you have to screen, and that's not easy. That's expensive, right? Screening is expensive. Like, it costs the healthcare system a lot of money. And because here it tends to be more private, very little public, people aren't going to pay for it. They're just not going to pay for it, right? But education might help a little bit to reduce those numbers, to kind of say, hey man, you should think of this, and it's worth the money, or if you can lobby the government to, subsidize cervical tests or something like that. But anyway, we're going into a whole different area there. But that's what you could do, right? If there was the option of screening your cervix with your phone, then I'd say you guys are ready to go. But unfortunately, we're not there yet. There are devices, but it's not your phone, okay? And so that's something to consider in the future, but and breast cancer is the same thing. You can't do anything with your phone on breast cancer, all right? There's nothing. Okay, actually, before I go through this, the impact of cancer is definitely going to be when it's detected. So we're going to talk about that. I can't remember what we're talking about. Is it today? No, it might be today. Sorry, I can't remember. But I'm going to talk to you about that. I'm going to talk to you about breast cancer, its detection, and how you can use AI in order to improve the speed at which it's detected and treated, okay? Which leads to, obviously, better health outcomes for your population, okay? And so that's what AI can do. It would be the same thing for cervical cancer, but for, it's interesting here in India, is it the same thing? Do you have to pay for a mammogram? You do. And so is it the same idea as cervical cancer that people won't do it because they won't pay for it? Correct. Yeah. So that's a problem. That's a problem. If you're not going to get screened, or same with colon cancer, right? Like if you're not going to get checked, you're just it's not going to happen, right? So if in your case, it's not funny. It's interesting that when I work in Costa Rica, the problem is not the screening because they do screening. The problem is the time it takes to get the answer. So that's addressable, right? Something that you can do as an engineer. You can work on that problem using AI. But in India, I don't know. We'll have to think about it a little bit. How can we improve access to screening? I don't know. Well, that's a tough one, right? Because it's money. So anyway, we can think about it. But okay, women's health. So actually, sorry. Let me. Yeah. What's that? Oh, we have to take a break now? Yeah, sure. Yeah, so we'll go back to this? Okay, so let me, yeah, sure. Yeah, you guys have to have a snack, eh? No, I'm kidding. Okay, so before we go for our snack, I'll just say one more thing. So, the idea of how we can try and get something to work in India, right? So remember yesterday we were talking about, I can't remember who asked. Somebody asked for data. How do you get data? How do you share data, right, from a private hospital, right? And I said it's all about value. Remember that? So that's absolutely how it's going to work, and in India. So I wonder if you go to a private institution, their goal is to make money, right? When I say that, by the way, don't think I'm saying that in a negative way. I own a for-profit company, so I know all about making money. It's not bad. The company's purpose is to make money, okay? So I'm not saying that in a bad way. Taking advantage of people, that's bad, okay? But just running a business is not bad. So a hospital is the same way. A hospital that's a private institution, they're making money. It's not necessarily bad. If they abuse you, if they take advantage of their clients, then that's bad. But if they're just running a business, then that's not bad. So what you need to do is approach them and say, hey man, what if we were to provide you something of value? So we're going to provide you with software that's going to be of value to you. It's going to provide you the ability to do what you do for less money, right? That's what the goal is. So I kind of wonder for this screening, it'd be interesting to know, how could you come up with an idea that you would put together an app, let's say, for screening for breast cancer, and somehow benefit the user and them, right? So the problem, of course, is that people don't know about it, one, don't want to pay for it, two. So if people do not have the funds to test, pay for that test, there's nothing you can do, they're not going, right? They can't afford it, they're not going to go. But there must be a whole percentage of population that either A, don't really know about it or don't think about it, and B, they got the money, but they don't really have the money. You know what I mean? They kind of have the money, but they don't have the money. So they don't understand the value of that test. See, once again, it's value. So if you could put an app together that would educate about screening for breast cancer, or let's go with cervix. Cervical cancer, so much easier, right? So you can't screen yourself for cervical cancer. It's not going to happen, right? Unless you're a physician and you can do a pap smear. It's not going to happen. So if you educate people about the seriousness of cervical cancer in your app, right? But then you collaborate with a local privately owned hospital and you say, hey, if you work with us in our app, and then you do, I don't know, you could actually develop some AI for, cervical cancer screening or something like that, right? You could say, we're going to share this app with you, and the benefit to you is we're going to bring you clients. Because we're educating the population and we're saying, hey, you should get screened for cancer, for cervical cancer, they may actually have the money. Some will have the money to pay for it, but they don't do it because they didn't get the little push to say it's worth the money. So if you educate them and tell them how important it is to get a cervical screening so you don't die, it's a pretty easy sell, right? But then you actually show them how the value of a cervical screening, and then you coordinate it with your hospital that if they come in through the app, the cost of the screening is cheaper, 20% off, I don't know, something like that, right? Your partner's gonna, well, if your partner is truly a good business, they would say, oh, well, yeah, that's worth it to us to give the discount, because if I didn't have you in your app, I wouldn't have those clients coming in for testing. And then what happens if they discover cancer? That hospital has to treat the cancer. And you can guess that if someone gets diagnosed with cancer, they're probably going to go out of their way to pay for it, right? Because they're not going to say, oh, well, thank you for telling me. I'm going to go over there and die now. That's not going to happen, right? So then the hospital benefits again, because they're going to get paid to treat that cancer. So do you see the value? So if you actually had a relationship, you as the engineer could work at putting together that app, work on the cervical cancer, it could be even just the logistics, right? Something like that. To just that whole program could be administrated through your app and through AI agents, all that kind of fun stuff. And then you have partners that are vested, they're interested. Because the client is interested because they want to save their lives. And the healthcare system, so your private hospital, would actually support it because they're actually going to make money. They're actually going to make money on it. So why wouldn't they spend money to make money? Right. Anyway, there you go. We can have a snack. We'll chat later. Is that... oh.
Good evening, everyone. So now we are going to continue the session by Pascal.
Okay, so where were we? More mental health, but we stopped off on, an idea of getting your private healthcare system involved and how that could, what that would look like, right? It's not easy. Been there, done that many times. And you just have to try, right? And keep trying. And eventually, you'll be successful. If you don't try, you will not be successful. Okay. Women's mental health. So nothing new here. I mean, I'm sure you're all aware of it. The reason we're bringing it up is because today we're talking about women's health, right? So why wouldn't we? But mental health is an issue because of the stigma. It has existed forever. Medicine has included it as part of health forever. There have been psychiatrists forever. There's, more recently in time is psychologists who do not prescribe, although that's changing now. But that's essentially part of the healthcare system, okay? The stigma is it's not real, right? It's all in your head, which is ironic because it is. But it's something that you can get over, right? Oh, just snap out of it. This whole depression thing, anxiety thing, just deal with it, right? So I think more recently it's been shown that it's not a mental only state, it's a physiological state. Physiologically, we are made differently. And in certain physiological states make you susceptible to depression, to anxiety. So it's not something you do, it's not something you eat, it's who you are. And so that's probably the biggest problem with mental health, is teasing out or making the distinction between a health condition and what's culturally acceptable. Okay? And that's the problem, is that, as we've evolved, I mean, it used to be that you wouldn't even admit you had, an illness, right? Of any form, right? Now you're pretty comfortable saying I have type 2 diabetes. People are like, oh, me too, So it's not really a big deal. But very few people are going to say I have clinical depression or I have generalized anxiety. No one's going to admit that. It's definitely changing in Canada dramatically, maybe in the last few years. Like literally that soon. There's also a term called neurodivergence. So neurodivergence means, people who have suffer from, autism, right? Or, that form of the spectrum. And so we put it all under neurodivergence. And that's acceptable now, right? To express that, to say that, you suffer from that. So it is changing, but I would say it's even more of a problem if you're a woman, unfortunately, because there are many stigmas around mental health in women, and it's going to take longer to go away, right? So that's the reason we're talking about it today, is all of this represents huge problems for data. Because remember, I'm here as a data scientist, right? I'm not a clinician. I'm not here to preach about mental health. But what I am telling you is it's a huge problem for you as engineers, okay? Just the gender issue is a huge problem. I'm just going to guess, and I'm not going to ask, but I'm going to guess that many here in the room would have had a hard time making the difference between sex and gender. Okay? So understanding the concept of gender identity versus sex at birth is right away already a challenge. Because how does gender affect the outcome you are modeling? You need to understand that because you're the engineer. And if you don't understand it yourself, how are you going to model it? So you need to work with your, who's giving you the data to better understand the impact of gender on whatever the outcome you're working with. There may be zero impact of gender. Maybe gender is not the issue. Maybe it's just sex. Maybe it's just physiological differences between males and females. Maybe that's the only thing you're modeling. Great. But if gender identity is going to change the behavior pattern that you are modeling in state transition for reinforcement learning, then you need to know about it. Okay? All right. We kind of hit this one already, but these are just the reasons that you have problems with your data collection. And I'll tell you another problem that happens is changes are happening in India, correct? They are. I mean, seriously. I mean, for me to even be talking about what I've been talking about like 10, 15 years ago would have been like, I would have been sent home, right? So it definitely is changing. And I'm saying same thing in Canada, right, by the way. If I had been given a conversation, talk like this, 10, 15 years ago, people were like, well, what, gender? That doesn't exist, right? So, you have to keep it in mind, because if you're modeling things over, I'm going to come back to it again. If you're modeling things that have retrospective data over time, you've got a huge problem, because the way it was collected changes over time. How we appreciate a gender has changed over time, right? There's even gender and sexual preference. So you have to keep that in mind as well, because that does change behavior, right? And it is part of the person you are modeling. And so asking about sexual preference in a form I don't know, but I suspect it's probably more difficult to ask for it here in India than it would be in Canada, right? So in terms of, now it's standard in our forms. Like when you fill it out, you'll have, if it's a complete form, you're going to have sex at birth, you're going to have gender identity, and you're going to have sexual preference, because they're all different. And so you're going to say, well, who cares? Like, why do we care what your sexual preference is? That's something that you do behind, at your home. And that's true. It's private. The only thing is, clearly, it makes you different. That combination makes you different. What your sex is at birth, what your gender is, and what your sexual preference is going to make you different than somebody else who has a different combination. So when I want to be able to know what drug to prescribe you, that may have an impact. I'm not saying necessarily, but it may, correct? And so I need to model that. So if you don't know that information, what does it end up becoming in your model? If you don't know those answers, and they do impact your outcome, what does that become in your data? Who here has done statistics? Come on, man, seriously. No one in the room has done statistics. Please. No? Oh my God, wow. You guys are so quiet, it's like crazy. So in statistics, when you're doing regression, who here has done regression? That's part of statistics, by the way, regression. So as an engineer, if you've modeled regression, you've done statistics. So the only thing is, if you're doing statistics, you're probably not doing it at the same level as machine learning, where you have so many parameters that you're just, your hands off. In classical statistics, you're the one who's modeling. And so then the variables you put in your model. So you have to understand, in a statistical model, you're trying to predict something using regression, correct? Your independent variables are predicting your dependent variables. So what is the most basic form of a model you can have? What's the most basic form of any predictive model? Give me an example. Ooh, what's that? So wow, that's not bad. That's pretty good. But that's actually already a little too advanced, because you now have a parameter for the slope, correct? I want simpler than that. Even simpler than that. Okay. So, but what is it? What's that parameter you're modeling? Doesn't have to be linear. I didn't say linear. Did I say linear? I didn't say linear. I said model. Okay. I want to predict the next person that comes in the room. Dr. Shikar is not here. I want to know his body weight when he walks in the door. How am I going to do that? I want to predict his body weight when he walks in that door. How am I going to do that? You engineers over there. How do I do that? What's the easiest way for me to predict Dr. Shikar's body weight when he walks in the door? It compares height. Okay, that sounds kind of complex though, doesn't it? I have to first know your height, and I have to know your weight, and I have to model that. Yeah. Too complicated. What's that? So actually measure his weight, so that's a measure. So I'm not predicting now, I'm actually measuring. So I want to predict it though. Come on, man, come on. Come on, you engineers. Too complicated. Too complicated. Dimension. So like spatial area. You know, like surface to volume or something. Way too complicated. You guys are thinking way too hard. Way too complicated. Screening how? See, you guys are thinking way too hard. You can guess. Okay. Now we're getting there. Now we're getting there. That's easy. That's easy. We could just guess. You're right. Absolutely, we could guess. And the chances of nailing it's probably not very good. Right? Although it's interesting that have you guys heard of Bayesian? Bayesian? Yeah, Bayesian. Oh, okay. We're. So that's Bayesian statistics. The reason for that is the precedent. You know your body weight, and you know your son's body weight, and your mom's body weight. So then when you guess Dr. Shikar's body weight, you're going to put it in that range. That's Bayesian analysis. But I don't want to guess. I want to predict. You still haven't answered it, and the reason you haven't answered is because A, you probably haven't taken my stats course, but B, you're thinking too hard. So what if I asked all of you in this room to step on a scale, and I took the average weight of this class? Wouldn't that be an estimate of the next person to come into this classroom, their body weight? I would actually be, the mean, if you have a normal distribution, is the mode and the median. I warned you guys when we were talking about stats. So, the mode is the most frequent number in the distribution, correct? So why wouldn't I pick that number for Dr. Shikar's weight? So what did I need to do that? All I needed was the mean. That is an example of the most simplistic model you can have. Okay? Now you guys are saying height, and you're saying surface area volume. So what's that? That's a more complex model. Because now you're modeling other independent variables to make a better prediction. The other one that's missing clearly is sex. Because on average, men are heavier than women. And that's a fact. That's not, there's no offense here to women. Just in general, they are smaller. You see, I didn't use gender, because that would be wrong. Because that's an assigned identity. Sex by birth, at birth, is a fact that women are lighter. But you do have smaller men that are lighter than larger women. So you have an overlap in the distribution. So it's not perfect. And that's the reason you would need sex at birth You would need the average weight of a class. That could be, a predictor. It could be height. It could be ethnicity, so ethnic background. It could be BMI. It could be, you see how the model becomes more and more complex? And now we're better at predicting. That is what we do. That's what data science is all about. But you guys are thinking machine learning, and so now we're working with potentially thousands of parameters. And that's the departure from classical statistics. If I put 1,000 parameters in my model in classical statistics, what do I get? You get a saturated model. It's a model that's of no use to you. Okay? You have to use another approach, which is machine learning, to deal with so many parameters, and you will never understand the relationship between all those parameters. That is the black box. Okay? That's the black box syndrome. So in women, the problem is you have so many parameters, but you're going to be missing a bunch of values over time. Things will be changed over time. The weight was collected over time. That causes problems. So if that is introduced into your model, what do you end up with? Uncertainty. The model has uncertainty, which results in error. Okay? Or noise. So when you have incomplete data, it results in noise. It results in error in your model. That's what you get. And that's what you should be worried about when you're modeling. Okay? Does that make sense? So I'm showing you reasons for why you're going to get noise or error in your model. It's because the data you collected is not the way you thought it was. Okay? Did we do this? Am I losing my mind? Oh no, okay, we're doing breast cancer. Did we not cover this? No, we didn't. We're doing breast cancer. Oh yeah, okay, no, we're good. Okay, sorry, just losing my mind. Okay, so breast cancer detection. So what we're doing is AI, right? So we've already talked about a lot about this and how to introduce AI. So the most obvious one, of course, is going to be cervical cancer. It's going to be breast cancer. How do we do that? So that's what we're talking about here. So here's an example of radiology. So I'm very fortunate. I have one of my students in my lab is actually a radiologist from India, and he's going to talk to you. He's no longer in India. He moved. Sorry, he's in Canada now. But he's come to Canada because he's interested in AI as a radiologist, and he would like to be a researcher in Canada as a radiologist, and be a radiologist. I believe he might pass his license in Canada. But he's going to talk to you about his experience working as a radiologist in India and all of the software he uses. But I think that's tomorrow or Thursday. I can't remember. Tomorrow. So what do we do? We're looking for this. Okay? Lesions, essentially, cancerous lesions in your breast. Can we do that? How do we do that? We use a mammogram, so it's using, ionized energy, right? So X-ray. And when you observe it, you say, whoa, that doesn't look good. That doesn't look normal. That's a lesion. And then, of course, you're going to biopsy it, and then that's going to be proof positive that you have breast cancer in stool biopsy. Okay? But imaging is going to give you that first screening. And so that's what we do in radiology is provide, or what you will do as engineers, is you will work at the best ways of processing the signal that comes from a memory. I'm very careful to state that we're not processing necessarily an image. Why is that? You engineers who are very quiet in the back. Why do I not only say image? What is an image? Okay, those of you that are clinicians, or you're NLP clinicians, you're forgiven. But for the rest of you, you're not. So what is an image? What's an image? Collection of pixels. Wonderful. What's a pixel? It's a
Intensity level.
yeah. Oh, intensity level. Sorry, I'm starting to get used to the accents and the dialects and stuff. So it's an intensity level. Excellent. That's correct. But what is an intensity level? It's a brightness. Certainly, but numerically it is a. It's a value. It's a number. It's a number. So what are images? They are numbers. They're numbers. Right? So it's yeah, exactly. It's location of the pixel in the image and its value of intensity. That's all images are. And that's why it's math. It's math. So why does the computer need the image? That image achieves the only of the effectivity. Certainly. But does it need the image? Does the algorithm actually look at the image? Sure. But is the algorithm looking at the image? No. They're numbers. Vectors. Matrices. Tensors. That's all it is. So, who needs this? We do. So remember, there is a loss of signal when you process it for humans. And so there's a lot of research that cuts out the image. So for X-ray analysis, it's a little different because it's a sensory plate that just, right? You actually get it. But how about ultrasound? Yeah, but what's actually the signal? Yeah, sound. That's converted, correct? So is it an actual image? No. So the only reason it's converted to an image is for us. But there's a loss of signal when you do that. So there's a lot of research that's looking, and it's same for CT, MRI, the whole thing, is they're looking to process the raw image that comes out of the scanner and not the image. Because think of it, it's being converted to an image, and then you're applying your math onto that image. Why not apply your math directly onto the raw signal? Okay? That was just an aside, but it's something to keep in mind. So here's your cervical cancer screening. So I suspect, that's just not common, here to have these. But these are portable. Right? And so that's kind of the future-ish, right? I mean, don't think this is, not every family in Canada has one of these. No, it's not common yet either. But this is where we're heading, okay? And so this is just an example of what you guys are going to contribute to as engineers, is building these. This would be a medical device, okay? In terms of, I'm going to guess probably this one is a class 3 medical device, okay? And these are used, they are used in India, but it's just not a common thing, right? Not yet. Okay, maternal health monitoring. So, inevitably that's going to be all supported, as I said, the support you have for pregnancy, right? So that you could contribute to this, right, in platforms and in phones, AI agents, right? You could definitely contribute to this type of monitoring. We've already touched on this, so I can zip through it. So mental health chatbots for women, of course. We've talked about this. Great, why not? Let's, go do it. Now you would include an AI agent, right? An AI agent is connected to an LLM, right? Gynecology for sure. So we do, we have a project that's underway in our lab for what's called an adnexal mass. So it's a mass that's in the cervical area in women, abdominal, cervical. And the tricky bit, of course, is you need an expert to take the ultrasound, and then you need an expert to review the ultrasound, et cetera, et cetera. And so we're doing, we're developing an algorithm to identify the mass, segment it, and all that fun stuff, just automated. it already exists. There's many other algorithms that do it, but what we're trying to do is fully automate it from what's called the cine loop in ultrasound, which is basically video clip. Okay, so when they take the ultrasound, they record a little video clip, and instead of asking the expert then to segment manually the area of the mass that they suspect is a mass, and then make the diagnosis, we take it straight from the video clip. So we cut out the need of an expert to segment the mass. So there's an example of where we're working on that. Of course, the early detection is key. So this is where it can be very impactful, is in LMICs, low middle income countries, where the ability early detection leads to better progress. Alarming, but it really is not a good thing. Lung cancer, unfortunately, is a killer. And so even if you detect it early or not, it's usually ends up. So that's a key. But in many other ones, earlier detection is better. Breast cancer especially. Because breast cancer, you can survive breast cancer successfully very old. Okay? But if you leave it for too long, it will metastasize. Breast cancer often ends up metastasis in the brain. Okay? So you want to capture it early before it has the possibility of metastasize. And that's your job, right? As engineers, is to put together solutions that are going to provide early detection. Okay? Access, so barriers to access is another one, which I have a particular interest in, as you know, for global health. But I just really think it's low-hanging fruit for AI. I really do. Right? Because you're so comfortable using it at home. You know, your phone, right? Accessing the internet, using your phone. Why would it not be a good vehicle for early access for some, not all medicine, right? You're not going to detect lung cancer and treat lung cancer with your phone. It's not going to happen. And that's okay. We can't fix everything. But there are many, many, many health concerns that can be addressed through simple technology. And what a shame that we're not taking advantage of it. Especially for those of you, and we're all, at fault of doing this, and that is, telling our children, oh, you're on the phone too long, oh, you use the phone too much, get out there, okay. Realistically, our children are not going to listen to us, right? That's true because I didn't listen to my parents. So, why would I expect my kids to listen to me? They're not going to. So, and the generation won't listen to the older generation. It's a fact, right? And there's nothing wrong with that. That's fine. It's just the way it is. But you are going to use your phone. You can't get rid of your phone. You're not going to have your phone confiscated. You are going to use ChatGPT. You are going to use large language models. So what's important is to use them right. And that's where our generation has a role. And that is to provide you with the education required to benefit from those tools. So by burying your head in the sand and pretending that you shouldn't use it, and our children should not use it because it's such a bad thing, it's going to rot their brains, as everybody says, all you're doing is delaying the inevitable. And you're actually pushing the use of the phone to somewhere where it's not governed, where there are no guidelines, recommendations. You're pushing your children to use it without your education and your insight into how they should use it. That's the problem. And so that's exactly what's going on with access to care. By not using it, we're putting so many people at a disadvantage. If we were all privileged, we were all rich and privileged, then it would be a non-issue. But we're not all rich and privileged. So why not leverage the technology as best we can to profit everyone, right? And that's, bottom line, that's what this is for. So all of these things are possible. Some of them more or less in terms of cost, so I'm mindful of that for you. Because I already know, my first startup company was a medical device where it costs money to use our medical device. So I was very, aware that I was actually developing a medical device for the privileged. There's no doubt about it. I knew that, right? So you just, as long as you're aware of it, it's okay. But I know there's a pay barrier. And it's going to be the same thing here. Hypertension, you say, oh, well, you can monitor your hypertension. Great, but you have to have a means to measure your hypertension. To do that, you have to buy a monitor. It's not cheap. Okay? So that's going to be a problem. COPD, same thing. You need to be able to test for it. And heart failure, which is once again, there's a medical device involved, right? Diabetes, we just had a fantastic talk about diabetes. So you do need to be aware of that, but there is definitely things you can still do that's cost effective, right? That there's not super amounts of cost, right? So that's the challenge to you, right? Is to find something that works for you here in your community. That's what you need to do. Future directions, we've talked about all this, right? So this is today. Keep an eye on this. The reason I brought it up, the reason that, Dr. Shigard asked for it was just to bring awareness to how he does it, right? Women's health and men's health is not the same thing. I used to go through this a lot. I worked at the hospital for 6 children as a scientist for 13 years. And so that was a problem for children, and I suspect it's the same problem in India, that children are small adults. They're not. Okay? The physiology of a child is different than that of an adult. Okay? So you can't treat illness in children as you do in adults. It doesn't work. But rarely it does. Okay? So it's the same idea. You can't treat women from clinical studies that were on men. Doesn't make sense. Okay? And so that's what we're just trying to emphasize today. All right? There we go. So that's it for, pretty sure? Yep. That's it for the women's health. And then I think we're going to segue into my first company. Yeah. Let's get a question. Anybody have any questions? No? Okay. Question? Okay. Awesome. All right, we're going to segue. So this is going to work well. Yeah. So, yeah.
You want me to take the first line because you asked me.
For which one, sorry?
First line is not good.
Yeah, no. You guys know me. It's just, yeah, there we go. So once again, this takes us back to my lectures online that are available for any idea. So you're welcome to access them. So what I'm going to do, I'm going to step back a little bit about data science, right? So what's the purpose of data science? All right. So, everything we've talked about is basically extracting information and knowledge from data, right? That's what we're trying to do here as engineers, is extract information and knowledge from data. But what you may not know, what I think you do, you suspect it because I've been talking about it so much, is that there are actually 3 pillars to data science. Okay? Here you are, computer science and engineering. Then you have the mathematician. When you apply math to the domain, you get stats. When you apply computer science to the domain, you get data processing. When you apply computer science and math, you get machine learning. And the domain expertise is always forgotten. And that's what we've been talking about so far in these 2 days, is that problem. That the physician, in the case of medicine, the nurse, any healthcare professional who is the domain expert, he plays an equal role in data science. You can deny it all you want. It won't make it true. Okay? And keep that in mind, that that's what you need in order to get data science. fair representation of all three. So basically stats, you kind of say math stats. You're not going to have a mathematician at the table generally, because that's too theory. It's applied math, right? So it's going to be stats, computer science, engineering, and your expert. And the three of you are going to make up the data science team. So these are the core values of a data scientist. Very messy, I apologize, but just to give you a look at the colors, right? Essentially this is business in kind of yellow. Green is machine learning and big data. Light blue is math. Dark blue is programming. Red is statistics. Those are the domains. At the top here you have the different types of people. Data business person, data creative, right? So kind of a storyteller. Data developer, and data researcher. So look at the way it's distributed, right? Like who has what. So if you're in business, obviously your biggest component is business. And then you kind of have a little bit of a mixture of math and machine learning and statistics and very little programming. It makes sense, you're a business person. A data creative looks very balanced with a minimum, at least maybe in math. Right? The data developer is going to have a big chunk of programming, which makes sense, less of statistics, lots of machine learning, and less of business. And the data researcher is going to have a lot of statistics. So you need to understand exactly what we've been talking about. You have to understand the data. Very little programming, math, of course, and machine learning, very little bit. So this just shows the ability, well, the most kind of balance is going to be the data creative. The data creative is someone who is the storyteller, someone who truly understands what's going on at all levels. Okay? So I would tend to fit here. That's kind of more what I do. You guys as engineers are going to tend to live here. Right? Lots of machine learning, lots of programming. Right? But you have to keep in mind, nobody's perfect. There isn't the perfect person. Okay? It's a part of a team. You're always a team. Okay, so what's this? I already told you about the story of big data. Remember it was volume, velocity, and variety. So lots of data coming in at once, different types of data. There's another two here I wanted to bring out. One, veracity and value. So veracity is not a common word, is it? But the reason they chose it because it's by use. So veracity basically means authenticity. Correct, right? The right data. So this is so you want to make sure you have the right data. And then the last one is value. Once again, there you go, there's value. That has an impact on your data. Does your data have value? Very important to remember when you're dealing with your data, okay? If it doesn't have value, then who cares about it? Okay, so let me give you a little example. So this was my first startup. It's called ACE, ACE Age, right? ACE, the process of age. And our product was called Carry. And it was a medication delivery device. And the medication delivery device was based on this problem of medication adherence. So who here, if you're willing to share, was prescribed antibiotics but didn't finish taking the whole course? Anybody here? Okay, feel it. The rest of you are out. Two shots. So medication adherence is the problem. And it's not usually antibiotics. The antibiotics is the problem. It's going to be medication for depression. Because the side effects are horrible. Right? I don't know if any of you, I'm not going to, but if any of you have been on medication for depression, And what it did was it delivered, you see here all it was a device that we literally put a cell phone here, right, in front of the device, and in the back is where you put your medication. So those of you that are in pharmacy, or I don't know if you're in pharmacy, but your medication can be delivered in cellophane pouches in a long strip. So those of you that have mom and dad, grandma, grandpa that are on lots of medication, instead of having all these bottles, you have them in pouches for each step and then you take the medication. So 3 times a day, 5 times a day. And so you roll that out and you put it in the back of this device. You put it in the back of this device, and what this does is through the phone, through the Android phone, it will schedule when you need to be taken, it will set an alarm, it will remind people of the circle of care. So it will remind you, the adult son, right? Grandpa didn't take your medication. And so you call home, hey, Grandpa, come on, man, take medication, right? So it's just a way of encouraging people to take their medication. So that's what the purpose was. And this is, obviously what you can plug into is activity monitors, and vital monitors, the whole thing. It's a big circle of care. So the reason I was involved, I was the chief science officer for the company, one of the co-founders and the chief science, the early founders, where there was 3 of us. And my interest, of course, is data. You're a data center. And so by collecting all this data and sharing it and processing it, I could use it for data. And so that's the reason I'm talking about it today. So here's, we're going through the V's. So volume, in this case, we assumed 5 million care units deployed in Canada, and each are scheduled for 3 medications a day. There's, when they're delivered, the name, all that information about the medication, the additional medication devices. Let's say they're plugged into a weight scale, or a glucometer, or a blood pressure monitor. So here's the volume. Here's the tons of data for 5 million people. 5 million people. That's our neighborhood, right? So in Canada, we're only 36 million. So 5 million people would be a large proportion of the country. Oh, sorry. So the next one is velocity. Inevitably, you have these 5 million people. So let's just say for you, 500 million. That'd be all right. So let's say you have 500 million people on this device. The amount of data coming in is a lot of data. It's a lot of data, right? 500 million people using this, and every time they press it and deploy it, and you get the notices. That's a lot of data coming in. So for you guys as engineers, you need to think of that. How do we manage all that data? The variety, of course, if you have different types of data. So we have logs, schedules, we have numeric data from measurements, we have textual data from questionnaires, in the morning, how are you feeling today? And then image data, potentially, we have medical video recognition of the medication, right? So that was a problem for us as a company, was that if you had people, that you're supposed to be helping people take their medication, what if they choose not to take their medication? So this device is not going to force them to take their medication. So video recognition is one of them, so then, you have a phone on the device, right? So there's a camera there. So you can just record. So they have to record taking the medication from you. So now you have video, right? That was right. Sorry. There we go. Veracity is, you definitely need it to, so the example of the video is you want to make sure it's accurate, right? And these days, all the deep fakes and stuff like that, right? Get somebody else who looks like me taking medication, right? That would be bad, right? So that's not going to work. And then why do it is the value. So what's the value of this data? Because storage of that data, storage of 30 terabytes. Back in the day, I was like, what? 30 terabytes, that's a lot of data. These days that is pretty manageable. But just think, 500 million. That's going to be a lot of data that you have to store, and that costs money. So for your company, that costs money. See, there has to be value in the data for you to use. So now let me tie it into a clinical value. For this problem of falling. And so for us, like in this at the time, probably a little more than this is when I had my company. So it's about $2 billion. So that's a lot of money, right? It's a lot of money, right? It's all in Canadian dollars, by the way. It's not. I guess for you guys it is much more. So what can we do? These are their risk factors, obviously. So the risk factors are falling. Right? So we need to assess why are they falling. So you have acute illness, obviously you have a fever, you have delirium, you have fall over. You know, balancing gait deficit, somebody brought up gait, for assessing weight. So that, you could just have gait issues. Chronic conditions and disabilities, of course, cognitive impairment, low vision, obviously not wearing any glasses, you know, the walk are going to fall over. Muscle weakness and reduced physical fitness, right? If you're not active like you're supposed to, you're type 2 diabetes, and you're not taking medication, right? But, whoops. So, behavioral risk factors. So those were like physiological. Now we have behavioral. I'm not going to go through them all. But, inevitably, what do we do? My mother is so bad at this. So she's 88, right? And she's from France. So when she dresses, she needs to look just like, right? And she has gait problems, right? She has heart failure, she has gait problems. But she recently improved. But she was only wearing little sandals because it looked nice. But you can imagine if you have, you're unstable and you're wearing sandals, you're going to trip. Okay, compared to shoes that are, like give you stability. Right? And so there's behavioral. Come on, mom, wear your shoes when you go for a walk instead of these little flimsy sandals. That's behavior. So when you look at the evidence, which you have to do when you do your project, right? You have to see why, what you're looking at is a problem and how you're going to provide a solution. Right? Once again here, complications related to diabetes, such as neuropathy, retinopathy, these are going to also contribute to falls. Right? So there, I'm just tying it into your type 2 diabetes. This is where all of this can tie in. Right? That's the evidence. We already went through diabetes. We got that. So the question is, what if we can prevent falls? So this is where we're now doing this is your project. How can, using our device, it's not my device anymore, it's open up. How can, using that device, prevent falls? And that's your question, and what you need to do using this potentially big data problem. Right? So, this is where AI can be used. So obviously, virtual assistant, this is just everything that we've done, and we've talked a lot about this, self-driving cars, it's everywhere. Healthcare, medical, imaging, and all, right? So AI in medicine, that's of course. This is more of what we were talking about in terms of, CAD, which we're going to do. The computer-aided diagnosis, my radiologist can talk about that. I'll talk about it as well. But what we want, I'm going to get to the disease prognosis and all this. Okay, so you know what? I might have cut out the slide I wanted to do. Sorry, let me just. Okay, I cut out the two slides. I was just gonna voice it. Sorry, let me get back to the end of the area. change the color of the screen, right? It becomes yellow, right? Red, oh my God, safety medication, call 911, whatever. I guess is there 911 here? Who do you call here when you want an emergency? Is it 911? Okay. What's that? Okay, so it's a little bit different. So I should know not to call 911. So that's what you modeling your risk based on those input parameters. So that's just a good example of how you would coordinate a model, prediction model, with a medical device. Correct. What a fantastic question. That's an excellent question. And that is the black box syndrome. Okay? So absolutely, if you have a very complex model, and you model it using a neural network, you're not going to know necessarily. You won't. Which of those variables contributed the most to the decision of the algorithm to say, whoa, you're a great. So how do we deal with that? Okay, great question. Oh, that's a great answer. You're absolutely right. Explainability. So what's explainability? These parameters are actually contributing. So how do I do that? Do I ask the model? Hey, it's a black box. I'm not going to tell you. So how do you do that?
Can we go to video maybe you be presentation in your own context, the way you there's a training which is on this really and you can direct this is kind of content to what you really want.
Yeah.
This is video.
Video analysis.
Yeah.
Yeah, actually there was a company in the UK that I was working with many years ago that was doing radar actually. So we were doing radar for exactly that. The reason they were doing radar is because video is not permitted, right? For privacy reasons. But they were doing radar. So you're absolutely right. So you could tie in that absolutely civil recognition. But no, let's answer the question, how do we get explainability? How do we know, how could we share with the user saying, hey, you're at risk of falling, and we think it's because you're not taking medication or you have something to do, something happens in your life, right? So how do we do that? Do engineers? Tough one, eh? So it's a very difficult area, by the way. So explainability and interpretability is a relatively new area and it's very difficult. So the most useful way of doing it is you do a parallel process. Okay? So you have a machine learning, deep learning, fantastic algorithm. And what you try and do is you model in parallel, another, like an explainable model. And by doing so, and obviously you match the outcome, right? You match the outcome. Make sure both models do that sort of thing. And then you can explain the neural network model by saying, we think what the model is doing is due to these parameters, because in parallel, it's looking. Is it correct? No. But is it helpful? Yes. It gives you an idea. For this solution that's very difficult, that's what we would do. In medical imaging, we're a little bit luckier because I showed it previously in the image. You actually I want to make the safety recommendations, I'm not a physician. And I think physicians will not do that kind of thing, because you don't really know either, because everything is different. And so you probably would, so you do a standardized approach, right? So if they're at risk of falling, you would tell them, please check the following. Did you take your medication? Are you feeling any different today? You know, did you know whatever, you know? Something like that. Please contact, you know, whoever. That's what you would do in the software. So that's a fantastic question, too. That's such a common problem. Any questions on what we've done so far? Sorry, what was it? 130. Oh, okay, good. Well, okay. That's not make sure I don't decide you as well. Okay, so any questions on that? So that's just an application. That's an example of an application to a medical device. Okay? The rest of the talk today is what this entire week is about, right? And so, you know, I'd rather go into questions in doing that, generally you do what's called distillation. So you're distilling your model, you're pruning your model, right? You're taking stuff away and then you're still working to make it smaller. Right? So that is a very interesting area of research. And academically, interestingly, it's not, my knowledge, it's not a huge area of interest because academically, more people don't distil their model. But in business, it's huge. Because everybody wants to put it on a mobile. The other bonus now, I kind of have the one bonus. Some people say, oh, I'm still behind the signal. But most new phones are AI ready. They have been designed to run it. And in doing so, they can accommodate larger, models. So the combination of that, doing the right programming, and then having your phone, your phone, will permit the use of your model on a mobile. And it doesn't have to be a phone, it can be a network. So if you're talking about a device, it'll be the same. It's extremely rare that you don't have some connection to the internet, but you need it to update it. Right? You need it to make updates to check on traceability, security, all that kind of stuff. So what we're also doing now, and I'm doing this in Costa Rica, is you have a light mobile version, right? So you're out in the field, and you're using butterfly ultrasound, which is a portable ultrasound that just plugs right into your phone. You have a transducer, and away you go. So when you're out in the field and you have no connection, it still works because I'm using, sensor flow light or, what's called hybrid mobile, or really the model. And it works. But my model is very basic. You can only yes, no. You can yes, no. And then, as soon as I get back to my clinic from visiting my patients, it connects automatically to the internet, and it runs the data again on another model, which is a full model, which now gives me ThyRAD, which is the thyroid, which is the RAD, radiology. It gives you a score, essentially, of the risk of it being cancer. And then it gives you that score. But I can't run that model offline. There's no way I could do it. So just the basic yes, no, I do when I'm in the field, but when I reconnect, I then do the full model. Okay? You're going to say maybe, usually I talk to medical audiences, and they say, oh, wait a minute, what are we going to get from a yes, no? Right? Lesion, yes, no. Well, what's nice about it is it's not only a lesion, and then the thyroid and multiple lesions. It does give the user who's not necessarily an expert an idea of, I should be scanning. That's usually the big one, right? So if you're doing a scan and you don't really see a leak or I'm not really sure, and then your software goes, beep, hey, then you go, whoa, wait a minute, I gotta check that again. Right? So that's what it does. It gives you a little guidance out in the field. It also records it. And so then it improves afterwards when you use that to okay? So yes, you're right. It's not going to be earth-shattering, but it will be for someone who's not fully trained. Because you got to imagine, I'm sure anybody, many remote communities where there are no signal, cell phone. Who goes out? Is he going to be the expert? Is the world expert on thyroid? No way, right? So who do you send? You send like Bob, but no clue to go out there and take pictures, right? So that's where the software is very useful. Because if the user, the professional, is not trained on the same level as the other healthcare providers, they can still do an okay job because it's telling them, look here, look there, move there, that was bad, whatever, and then, okay, I better get all this, and then you go back and do the make sense? So that's the advantage of I'm just using ultrasound, but of course, there are other portable devices. Ultrasound is just common as well. Obvious, right? I mean, people are kind of saying portable ultrasound is the new stethoscope, right? So you're not a physician unless you have a stethoscope around your neck. I mean, you see that in hospital? There's a physician. But what do you use a stethoscope for? Come on, like, is it really that useful? I mean, get caught, You want to just try sharing your slides again, just see if it does share, or because you can't hear me? Oh. Can you try sharing your slides again?
Can you please share the slides because I cannot share the full screen.
Oh. Okay. So can you share them? Yeah, go please.
I cannot share.
Oh no, there you go. Yeah. Oh, you can't show the full screen. Hit presentation mode, bottom right. Yeah, yeah, try that. Let's just.
That will work.
Oh, okay. Yeah.
Their reflected seafoods are received by the transducer and then converted to electrical pulses for further processing. These received pulses are technically called radio frequency or RF waves. The greatest scale that is shown after conditioning is called remote image, which is an envelope of the RF data. Next slide, please. Here is an example of supercellular mini ultrasound, which means using ultrasound to look just above the kneecap or patella, where fluid like hemophilia often collects. Identifying structure like tumor, valvular tendon, and supercellular research is essential for detecting bleeding. The challenge is that interpretation requires expertise, which is where AI can make an impact to help automate or augment human interpretation. On the right side of the image, you see the calculation for obtaining these supercellular longitudinal scans. The ultrasound transducer is positioned above the patella, aligned with the timeline axis. Now, let's shift to AI bias. Bias can creep in at many levels, like data imbalance, labeling, algorithm design, and disaccuracy. For example, if certain groups are underrepresented in the data set, the model may underperform on them. Or if human labels are subjective, those biases get encoded into the model. These biases are not just technical issues, they have real clinical implications. Next slide. Here we want to see an example that moves the discussion from theory to reality. Not just that bias can happen, but that it already has in a real-world healthcare system. A hospital algorithm was trying to predict which patient needs extra care. But instead of using actual health data, it used how much money patient spends on healthcare at the cost as a standing for how sick they were. What was the problem? Problem was that Black patients often received less care than white patients. Not because they were healthier, but because of systematic inequality, which means less access to care. So the algorithm wrongly assumed Black patients were healthier since they cost less, and recommended less care for them. This shows that bias in medical AI has real harmful consequences. Another type of bias is imbalance. What is the problem? Problem is that when there are imbalance in medical imaging data sets, produce biased genetic classifiers with significantly lower performance in underrepresented groups. So by training with imbalanced data sets, performance is poor, including, for example, male patient for training and female for testing or vice versa. So what is the solution? The solution is that training with a diverse and balanced data set to achieve the best performance for both genders. Diversity should be prioritized when designing databases used to train AI and ML algorithms. Next slide, please. When models are trained only on male or only on female patients, they get patterns that do not generalize well across sexes. The mainstream model focuses highly on the need for male images, but then applies to female images, which shifts attention to irrelevant areas. The opposite happens with the female trained model. Only the sex-balanced model consistently highlights the correct gene area across both male and female Next slide, please. Here we can see image source healthcare locations that we use for our studies in the next slide. This slide looks at sex-related bias in musculoskeletal remote outcomes for the testing research system. Just like the previous example, we see that training only on one set can see model performance. Looking at the figure on the top right, then the model is trained only on male. Accuracy is slightly higher for male, which is 85, but not for female, which is 83. When trained only on female, performance rate is better on female, 88, than on male, 87. The most balanced outcome comes from training on both sexes, giving equal accuracy of 88 for both groups. This shows that model trained one sex is generalizability. Now at the bottom, artifacts from a naked later for positive representation. The model trained with both sexes highlights the high convergence consistency, selective. The main only model is the observer, which is the negative map, but the female only model then applies to a male case is focused entirely and gives a feature probability, the right one. This mismatch illustrates how sex bias affects interpretability and confidence and prediction. So the picture is clear. Balanced data set reduce bias, reduce robustness metaclasses, and make AI models more reliable in real-time compute. Without this, performance may vary unfairly between male and female cases. Next slide, please. Another challenge is pediatrics. Data on hemophilia is scarce, but pediatric hemophilia is very different. Most AI models are trained on adult hemophilia, but children joints are fundamentally different due to growth rate, classification, and heart rate. This makes it difficult to directly apply adult-trained models to children. That is where generative AI comes in. Using GIAN, you can generate realistic age-specific synthetic ultrasound images. Next slide, please. Here are the steps for synthetic data generation that we applied in our work. Step 1 is load and resources for pediatric ultrasound image. We had 3 age groups for 0 to 8, 9 to 10, and 40 to 8. We load you, and we had positive and negative representation for each other. We load them with each other. So as I mentioned, the problem was that pediatric movie data is very different. So what we do is we use conditional GIAN that trains on all images. So if it's preferable, then data are kept using conditional studies. So all samples share the same platform, so rare that for texture or structure, we just age classifier to record synthetic images matching the intended group. So here we can see that for 0 to 8, 9 to 13, and for this age group, graph can show that the model look at anatomical relevant reasons for age appreciation. So this gave us additional confidence in the quality of generated images. Here you can see performance across pediatric age groups 0 to 8, 9 to 13, and 14 to 18. New model on pediatric data with synthetic data, consistency of telephone validation, adult training model, or optimistic. This shows that the real benefit of using synthetic pediatric data leads to better accuracy, sensitivity, and specificity, especially in younger children. So to summarize, hemophilia present unique diagnostic challenges, but AI-enhanced ultrasound offer promising solutions, but we must carefully address bias in our models that generative AI provided a pathway to overcome data sensitivity, especially in pediatrics. Thank you very much for your attention. I'm happy to take questions.
Okay. Thank you very much, Nushin. That was excellent. We'll open it up for some questions. I'll ask the audience first. Anybody have any questions, specific questions? Yes, sir. Could you use two different classifiers, male and female? Excellent question. What do you say to that, Nushin? Did you hear the question?
I didn't hear.
Yes. So the question is, why not use, in your case, why not use or train a separate classifier, one for male and one for female? that is a possibility, but it's very tricky because, as you know, inflammation would cause an increase in temperature as well. As you know, especially in heat, right? So it is tricky. So great question, though. And the reason I like that one is because that's exactly what you all need to do. Those are the questions you need to ask. Those are the questions that you team would ask at the beginning of a project, right? Is, what do we have to work with? Is it possible to improve our model by taking the temperature profile, for instance? So that's actually an excellent extension, right? If you were to consider a multimodal model, you could potentially feed in the temperature profile to improve the detection and actually make a difference. So this is another issue. So machines working on recess sensing detection, so meaning whether there's fluid or not. But how do you know if there's blood? And I think that's what you were alluding to. Is how do you know it's blood? Because in ultrasound, you saw the images. I mean, is anybody here a sonographer or works in the area of scanning? No, probably not. Right? So when you looked at that image, you went, can't do that. It's not recognizable, right? So just imagine how helpful it is if you can actually, work with several different indices and to make that diagnosis, right? That you have recess suspension and feed into your blood, or is it into what's called synovial fluid, which is inflammatory fluids that come about because of inflammation related to arthritis. And that's actually very important to know. Our users are very interested in knowing, is it blood or is it inflammation or is it both? It's very tricky to do. So then that would be an example of where we could be, possibly multimodal learning. Any other questions from the team? Okay, I do. So Nusheen, can you do me a favor? You've done so much of this. Can you please explain to all these young engineers what were the challenges in generative AI that you faced in this project? So they're interested in doing this, right? So can you share with them a little insight as to what was challenging and the challenges you had to overcome?
Yeah, so the whole time the data was running there. So, so we know that the GIAN is better in compared to other generative AI and for data strategy part. In reality, it was very there. So how I could it was very challenging. Because if I use conventional again and just to generate the synthetic images for each age group separately, I couldn't get a high quality images. But with conventional again, because I could get the shared features from all age groups, then I could get their synthetic images. That was one of the main challenges.
Yeah. So in terms of so explain to the group a little bit how StyleGAN was able to build on, right? That's what you were alluding to, is that instead of compartmentalizing or instead of grouping all the data into the various groups that you want, which is the problem is you end up with no data. To train the StyleGAN, by the way, using the raw data. You trained it all, right? And then what did you do? So that, like how did you do that? Like, you know what I mean? Like you grouped all the data, and so how did you get StyleGAN to actually afterwards correctly answer your question for Sal again? Yeah, good.